I think that makes the most sense. I do want to take a step back and say that, my expertise is kind of in the clinical realm. I'm not a professional data abstractor, so, I usually learn as much or maybe more from these sessions from you guys than you do from me necessarily. So the whole idea here is that it's an open dialogue. If I said something in one of the two training sessions that people don't agree with or would like to have more information about or discuss further, by all means, I am the farthest thing from like the final word on a lot of this stuff. So, feel free to interrupt and interject and ask questions as we move through. And I will get to some of the questions that came in beforehand. I do think it's important to clarify a lot of the chronic lung disease questions because there is, a need for a lot of clarification there. Okay, so if we're going to work off the data elements, I guess we would just start, 1 through 10, and I'm kind of operating on the assumption that everybody has at least run through the 2 videos that we have so that there's a little bit of kind of background knowledge here. I don't think that the first really 20 are particularly, contentious as we move through. So obviously medical record, the type of cabbage, we'll talk about that in a little bit more detail. But these things are, this is just, pulling data from the chart, essentially, date of surgery, date of birth, patient age, sex or gender we've talked about, race, for what that's worth. Then moving through the surgeon, first name, all these other things. Is there any real question from anybody from the standpoint of data elements 1 through 21? Is that a fair question just to throw out there and see if anybody?
I think so.
Okay.
Denise will be monitoring the chat. If people are more comfortable typing questions in the chat, you can pause for a second or raise your hand. Denise, let me know also or let us know if somebody's has their hand up. A question came in just recently about type of cabbage, and a reminder to all the hospitals that type of cabbage is one of those data elements that is unique to CCORP. So those exclusion lists are something that are related to CCORP. They're discussed by our clinical advisory panel and evaluated every so often. So it is now a data element that might require you to do some work separate from what you submit to STS for those of you that submit to STS.
Okay. Okay. All right. So, yeah, I think, we'll pause for a little bit, and if nobody has any questions, then we'll just kind of move on to the next set.
I want to add one more just note for those of you who weren't on the most recent conference call. I think people are aware that STS is now considering any patient that's discharged to hospice as a 30-day mortality. We will not be adopting that with our measure of mortality, since we have that ability to link to the state death records and to the inpatient data. So we can track patients a little better and not rely on that, and perhaps code patients that didn't die as if they did.
So we've got a couple questions from the chat. First question, any changes to existing inclusions, exclusion documents for type of cabbage?
We did not, I don't believe, in this version change. Denise, you can correct me for everything that went to STS or to OAL. We did not change the inclusion list.
Yeah, we did not make those changes, no.
If you have, especially exclusions that come up that aren't on the list, feel free to send those to us, because we will be discussing that at our next clinical advisory panel meeting in March.
Yeah, I do think that that's probably the best thing to do with some of those, the things that pop up in the surgeon's note sometimes sound more complicated than they actually are. So to kind of, defer and to try to figure that out, I think is beneficial.
I have a little anecdotal story to tell. Those of you who remember Dr. Steinley and Dr. Matchison may have used this example as well, that amputation is an exclusion. He does not, there's no thought that anybody would amputate a little toe just to get out of calling a cabbage isolated. Well, the auditors were auditing a record yesterday, or Wednesday, yesterday, Tuesday, and they came across a patient where the little toe had been amputated, so it was a non-isolated cabbage.
Oh my gosh. Oh, that is remarkable. Absolutely.
So we've got another question for
Sure.
discharge date that refers to the initial hospitalization. Correct. We do not follow patients transferred to other acute care hospitals. I can answer that one.
Yes,
the
go ahead.
discharge date is from your hospital, the hospital that
Right.
the cabbage occurred, not the transfer hospital.
Yes,
Okay.
that is one where we've added, we've made that with the version change, added that so we can gather that information. We need the discharge date from your facility.
Next question, on mortality, CCORP is not considering discharge to hospice as operative mortality, correct?
Correct.
Correct. We are not following what STS is doing on that one.
Okay.
And then one last question for now. Has core matrix patch for repair of pericardium or sometimes vessels been added to not exclusion?
Can you say that again, Denise? What was the?
Sure. Has core matrix patch for repair of pericardium or sometimes vessels been added to not exclusion?
Yeah, patch repair of pericardium. Is that what the question is?
Beth, if you want to unmute yourself and elaborate, that would be great.
Hi, can you hear me now?
Yeah.
Yes.
We code for the core matrix patch. And so every 6 months when we have to go, submit our data, we get flagged for that we should call it a non-isolated cabbage because they used core matrix to reapproximate when they were closing the pericardium. But it is not per STS standards. It is, and it does not exclude them. And so we have to send that detail in every time.
Yeah. No, I would agree with that. I mean, for the by and large, there's no indication to close the pericardium in the first place. But if they decide to use that and utilize that, I would say that's not an exclusion. Yeah.
I also want to add, if it's on the DDR, you don't have to send in documentation to us on that.
Okay.
Okay, we have another question that came in. Number 17, discharge date, and number 20, transfer date, should be coded as the same date.
Discharge and transfer. I would think so. I don't know
too.
I don't know where discharge and transfer would be different dates. But the transfer has to be to different facility, right? I mean, that's the important thing, is not just transfer from one unit to the other inside the hospital.
Correct.
So those have to be distinguished, obviously. But yeah, if it's discharge transfer to another facility, it'd be the same date.
Okay, another one came in. Is a bypass for anomalous takeoff or of RCA considered isolated or non-isolated cabbage?
So we haven't been including those, as I understand, because that's not getting at your prototypical cabbage patient. Those patients are completely different in anatomy and pathophysiology. Does that make sense? That's what we've been doing, right, Holly, for things that are congenital cardiac anomalies, anomalous coronary artery disease, or anomalous coronary anatomy.
So on the screen now are certain congenital anomalies, but not closure of the PFO. So if you see, I don't know if you can see my screen, Dr. Matchison.
Yeah, but I think that this question is getting more at like somebody has an anomalous circumflex that goes in between the aorta and the pulmonary artery, and that puts them at risk for sudden cardiac death. So they'll actually undergo, depending on how the surgeon wants to handle it, they might have a reimplantation of that coronary. But I would consider that not reportable, or, I wouldn't report that as a CABG.
Oh, I see what you're saying.
Yeah.
Yes. So, on things that are possibly coded as a CABG by your administrative group, or if you think there's a CABG, we usually say submit it to us, report all CABGs, and then send us the documentation if you think it's something that should be excluded from public reporting or excluded as a CABG. They're not too frequent, so we're happy to review those.
Well, that's it for questions so far, unless anybody else has any for the first 20 data elements.
Okay, so move on maybe? We can always come back if anything comes up. Let me pull this up.
Here's a request. Will all the participants please put the element number in their questions? This will help with referencing the training manual if pulled up to make notes locally. I think that's a great idea.
Oh, great. Okay, so the next 10 would get us into, diabetes, dialysis, hypertension, endocarditis, and then the big one, which would be, I think, chronic lung disease is included here, or maybe not quite. Let me see what you have.
Yeah, let's maybe go right up to
right.
chronic lung disease.
Let's not bite that one off just yet. All right. So diabetes, dialysis, hypertension, and then up to endocarditis. Any questions there that come up? I don't think there are any pre-submitted questions on that group.
Anything coming in the chat, Denise?
Nope, not yet.
All right, well, again, we can probably come back.
Sure.
Let's move on forward.
All right, you ready?
We're ready.
All right, so you want to take on chronic lung disease next then?
Yeah, you could probably start with some of the questions that came in.
Definitely. Okay, so let's do some clarification to start off with. The first question was, during the training, I stated that being on continuous home oxygen should be coded as severe lung disease. And then it goes on to kind of state that this is the first they've heard of this, and they asked for some clarification and confirmation. So home oxygen, if it doesn't have supporting documentation, I think home oxygen alone is going to be coded as lung disease, but severity unknown. So you're going to need additional assessments to have them kind of stratified as mild, moderate, or severe lung disease. But the home oxygen in and of itself would be coded just as unknown. So lung disease, yes, chronic lung disease, yes, but unknown severity. So I might have misspoke in that presentation. Again, if anybody disagrees with what I'm saying, by all means, interrupt me. But that's how I would approach that. And I think that's consistent with what we have in the training manual also. Yeah, so the STS clarification, patient on home oxygen without documentation, COPD, or PFT's ABG testing are coded as unknown. Let's see. And then the next question I have, confirmation, if a physician documents moderate COPD, but no PFT is completed, no ABG is performed, and the patient is not on chronic medications directed at lung disease, then we should answer lung disease documented severity unknown. So I believe for this, we have wanted additional kind of objective measures of severity of lung disease and not just the diagnosis. So that's why this would be an unknown.
Right.
Correct? Anything else? Okay. All right. The next one addresses, I guess STS recently adopted DLCO as a measure or as an indicator of chronic lung disease. So the update, November 2020, DLCO can be used to determine severity of lung disease. And then it talks about how it gets stratified out as mild, moderate, and severe. So previously, we have not been using DLCO. And that's what we have here in the manual too. DLCO should not be used for determining chronic lung disease. Is there any intention in changing that to align with STS now, Holly, or how are we going to handle?
Yes. So just to clarify, we made the decision to keep the training manual as it was set for your training videos.
Mm-hmm.
And we didn't add the clarifications that have come in from STS at this point. So we thought we would discuss some of those today. After this meeting, we will update the training manual with all relevant clarifications and any additional discussion that we have here. Is that clear to everybody? I meant to mention that at the beginning and I forgot.
Okay. Okay, so I think that addresses that question then.
So, and for future questions as well, but feel free to ask if there's clarifications that have come in from STS in the last few months that we have not added and you want to ask a question about those on any data element, feel free to ask.
Okay, perfect. Let's see this next question. Oh, the next was a question of asthma being able to be coded as chronic lung disease. Historically, we haven't considered asthma because asthma is more of a reversible lung process, acutely reversible. And a lot of those patients are on inhaled steroids, like rescue inhalers, albuterol, for example, but it doesn't quite meet criteria. So I think for asthma, if they have other objective indicators like abnormal, FEV1, for example, I think that it would be reasonable to code these as chronic lung disease, but just having the diagnosis of asthma in and of itself, it would not constitute chronic lung disease. And I also think you have to be careful about the therapeutic strategies for asthma because they may be on beta adrenergics or they might be on, steroids, but this is a reversible process. It's not a chronic lung disease. So what I would say with asthma is that if they have other objective measures that meet criteria for chronic lung disease diagnosis, I think that would be appropriate.
So we have a whole bunch of questions in the chat about chronic lung disease.
Oh, yes.
The first one, acute respiratory failure, no prior history of chronic lung. How do we code this?
I would not, acute respiratory failure is part and parcel for either, cardiogenic shock or acute heart failure exacerbation. So I don't think that that would constitute chronic lung disease. It does, unfortunately, it plays into it very often because when these patients, if they have, pulmonary edema, it can generate spurious results, abnormal results for like PFTs, for example. So that kind of has to be sorted out. But I think that's why it's so important for these patients to carry a diagnosis of chronic lung disease, a previous diagnosis of chronic lung disease, for us to kind of help us kind of flesh out what is a patient with chronic lung disease versus a patient with flash pulmonary edema, for example, from an acute myocardial infarction.
So the next question is moderate states or oral systemic steroids, but there's no discussion of inhaled steroid. Oh, I think that means manual. Manual states oral systemic steroids, but there's no discussion of inhaled steroids. Where does this fit?
So that's mild, right? So mild is chronic inhaled or oral. Oh, I guess those are bronchodilators. As opposed to moderate is chronic oral or systemic steroids. So the question is, what do we do with inhaled steroids?
Hey, Beth, would you like to unmute yourself and clarify?
Yep, that was the question.
Yeah, I think that would be in mild also then. I think if it's inhaled as opposed to systemic, just like the bronchodilators, inhaled corticosteroids would be mild.
Perfect, thanks.
Okay, the next question is sleep apnea using oxygen in the night.
That's a great question. Yeah, I would think that would not constitute chronic lung disease. That's an apneic issue. It's apnea resulting in hypoxia. So it's not a problem with the actual lung parenchyma, which I think this is what this data element is really trying to get at. There's no doubt the patients become hypoxic, but it's more because of the apneic episodes. So I would say no.
Alrighty, next question. We have had patients from out of the area who see pulmonologists out of the area and come in with diagnosis of severe COPD. Surgeon during operation sees lung and states very severe lung disease, but we have no PFTs. How is this coded? We can't get outside records.
I think historically we've said that this is chronic lung disease, but severity unknown. I mean, that's a tough one because they probably do have severe lung disease, but there's no objective measures of that that are being reported.
Right.
Okay, the next one. Patients can have long-standing restrictive chronic lung disease, maybe on long-time home oxygen and no reason to have acute PFTs. ABGs pre-surgery is an MD documentation and H&P to code a severity level.
Well, you can pull that in. I mean, so if they have an ABG, I mean, that's just as valid, right? So that information would be there. But I mean, yeah, if they don't want to do PFTs, they're not giving us any objective data. I think we just have to decide, you just kind of have to draw a line in the sand with this. And for the vast majority of these patients, we need a previous diagnosis or a diagnosis in the chart, and then we need something objective to help us stratify whether or not they have mild, moderate, or severe disease.
Okay, next question.
Sorry, Denise, but going back to for that patient who's on home oxygen and has a diagnosis of chronic lung disease, that's severe lung disease. That's as opposed to the patient who is on home oxygen but doesn't have anywhere in the chart a diagnosis of chronic lung disease, COPD, emphysema. Those are the patients who are chronic lung disease but severity unknown.
Okay. So if PFTs show a FEV1 demonstrating severe lung disease, but there is no provider documentation of chronic lung disease, then is that coded as severe?
What are we doing with this? I get confused on this. I think we're saying yes. And then it just has to be taken into clinical context, you know, because like I said, there are a lot of things that can result in an abnormal bedside pulmonary function test, like active heart failure decompensation or sedation on board or a balloon pump where the patient can't sit up and give a full inspiratory expiratory effort. Yeah, but the answer is yes. If it constitutes that, then it doesn't require physician documentation. I think that's what we're doing.
Okay. Another question, how about asthma with chronic medication?
Yeah, again, I think with asthma, they have to demonstrate, they really should demonstrate an abnormal pulmonary function test or ABG or something objective. That's what we've been doing historically. Historically, we said asthma in and of itself is a reversible lung process. Isn't, but I think now asthma, if you have an abnormal PFT to go along with it, then that would be chronic lung disease, and then you would stratify it accordingly.
And then here's another question. ECMO prior to CABG, is this CABG plus other, same patient, CABG plus ECMO, no CPR, en route, emergent, not salvage? So this looks like a type of CABG question, not a chronic lung disease.
Okay. So it's ECMO up front and then CABG?
ECMO prior to CABG, is this CABG plus other, same patient, CABG plus ECMO, but no CPR, en route, emergent, not salvage?
Well, if the patient's on ECMO, that's a salvage therapy. That's a salvage. Because ECMO is complete
Any
cardiac
timing?
replacement.
Was any timing noted there?
Hey, Nancy, would you like to unmute yourself and clarify?
Hi, can you hear me?
Mm-hmm.
Yeah.
Thanks. So it looks like during the PCI and received CPR several times, then got put on ECMO and then went to CABG. But I thought for salvage, you have to be eCPR en route, pressing on the chest, and that wasn't the case. So I wasn't sure if I can pick emergent salvage or emergent.
Yeah, I think because it's full cardiovascular support, that's as valid as CPR going into the operating room. I think for salvage, we've said ECMO, Impella CP, which is again full cardiovascular support, or active CPR rolling into the OR.
Okay, so would I also say resuscitation if it was in the cath lab?
Well, the cath lab would be resuscitation, yeah.
Okay.
Yeah.
And then the last question, so is it a CABG plus other?
Well, it's salvage, so it's just not included, right?
Right, but I think I got one of the DDR reports saying that I need to make it an other or CABG, yeah, CABG plus valve.
I guess CABG plus other would be fine then.
Just a reminder that the DDRs are just not always exact, but something we would like you to look at. That's it.
Okay, so it should be another then. It will get thrown out. All right, thank you so much.
Yeah, it will get thrown out.
Okay, thank you.
Mm-hmm.
So now we have a comment and a question. We are getting back into a gray area now if FEV1 is being accepted as diagnostic of chronic lung disease without documentation of it in the chart. This has been the $6 million question for the last few years. Can we code on FEV1 alone or not?
Holly, can I phone a friend here? What do we think about this? And if we could just come up with some sort of consensus and then just move past this, if there's only pulmonary function studies. like I said, I mean, my take on this is that you need a diagnosis and then you need something confirmatory. You need a diagnosis and then you need something objective. Because with pulmonary function studies alone, I just feel like there's too many other things that can affect it. So that if you don't have a pre-existing condition, the pre-existing lung condition, I don't know. I feel like
I'm trying to just read through the definition again.
Yeah, yeah.
You know, has anybody sent this type of question into STS, and what do they say?
I have a comment lower down that says STS has said yes for them. We can code based on FEV1s alone.
Okay, well, I mean, if you want to align, that makes our lives easier. I don't know that it's necessarily 100% accurate, but it just means you're just pulling that one.
Time we disagree, but
Yeah.
yes, we certainly don't want hospitals going back in and patient by patient recoding and checking on that. So, we can add something to the training manual that would clarify that.
Okay,
And
but what's the clarification then? Are we going to say that we need a diagnosis and then the PFTs are going to be for stratification, or are we going to say all we need is PFTs?
What does it say down here?
Well, there's one PFT there. I haven't seen any diagnosis. Code severe, so it's right there.
Yeah, there's an example right there in the
a
patient with the PFT. Yeah. So that's some of the examples that they've put forward. So maybe we don't need to even add anything.
Okay, so is that how you want to move forward then? By abiding by that example there?
Yes.
Okay. Perfect.
Okay, let's see. There was a comment. STS recently wrote back that if it was aiming at treating chronic lung disease, could consider.
What does could consider mean?
Yeah. Let's see, here's another one. For hospitals without ECMO, Impella is used in dire situations. If patient has no underlying circulation, so Impella flow is all they have, is that salvage? Would qualify as salvage if ECMO was used, but since we don't have it, Impella is the highest level of support available.
Yeah. Let me think about that. I mean, it's just not, it's not complete replacement. So that's the thought, is that those patients, I don't think we can say that, because then we're going to have to go out and sect out every patient who's on an Impella CP going to the OR and try to decide whether or not that's salvage or emergent.
That was my question. May I give a clarification?
Sure. Yeah, please.
It was clearly documented that the patient had absolutely no underlying flow at all. It's not that we're just using Impella to augment. It's clearly documented that there's no flow whatsoever. The patient had no spontaneous anything. And it's the physiology that would qualify for salvage, not the modality of treatment is the question.
Yeah, no, definitely. I mean, I totally understand that. I mean, I've done PCIs on patients where they have zero flow. They have no pulsatility whatsoever. They're completely dependent upon the Impella. But then you revascularize them. I totally understand what you're getting at, but I have to think a little bit more broadly about, okay, if we start to say an Impella CP can sometimes be considered, a salvage therapy, then we have to kind of, that opens up a whole, can of worms about every patient going to the OR with an Impella in place.
No, only those with no underlying flow. See, the problem is based on a treatment that if the hospital doesn't have it, you're treating salvage physiology, and just because we don't happen to have that machine, we're coding differently. The physiology is still basically moribund. I mean, they're
Yeah.
basically there's nothing there.
Yeah, I think that's a case that would, I would have to, that would need to be reviewed.
Okay.
So I think that's fine. You could raise a red flag, question salvage, and then we would go through that. Because I completely understand what you're saying. I mean, a lot of, community hospitals don't have, a 5.0, and they don't have ECMO. We don't even have ECMO where I practice. So I totally understand that.
Okay. So that would just be on a case by case.
Yeah, I think that's the best way to deal with that. And we really have to kind of like drill down and see exactly what was going on at that moment in time. But yeah.
Okay. Thank you.
Yeah, of course.
Okay. In regards to question about ECMO and other, ECMO is not to be entered as an other procedure. This was discussed with STS and is stated in the manual.
Okay. I mean, again, those cases are going to be excluded anyway.
Right.
ECMO plus CABG is just supposed to be CABG alone? Is that what that's saying, Denise?
It's for STS, maybe, we don't have that. It's not considered a exclusion, but we would call it a salvage. So
Okay. So we'd get to the same place, essentially.
Yes.
Yeah. Okay.
And then here's a comment regarding Impella. Perhaps we should consider those cases case by case and submit to CCORP for review and not change the intent of the definition.
Yeah, I think that's exactly it. I think there's a question if it's an Impella CP and that's all the facility has, and looks like the patient is dying and it's more of a salvage, then yeah, I'm more than happy to review those cases.
And then CABG plus valve plus lung wedge equals other?
It has to be a sizable resection of the lung. But yeah. Yeah, so not just like, lymph node dissection or something like that, but it has to be a significant resection of the lung. And obviously that's kind of a gray area diagnosis or definition too.
I think we've had that question before, and we had some sort of visual, but I can't remember what it was.
Yeah, so we say resection of lobe or segment, which would be kind of a wedge resection, but not simply biopsy of the lung or a node.
Yeah. So I think I got through all the questions in the chat, but there was a hand raised, but it went down. Abdul, did you still have a question? Sounds like not.
Yes.
Did I get it? Did I get everybody's question? Oh, go ahead. I'm sorry.
Yeah. Yes. I have the question only about the FEV1 and diagnosis of chronic lung disease, because I don't know if it is by itself we can consider as chronic lung disease without FVC and FEV1 FVC ratio. If we have that ratio and it is under 70%, we can be considered as chronic lung disease. But if we have only FEV1, I don't know how we can call it as chronic lung disease. That's only my comment.
Yeah, I think we just have to go back to how we use those as severity stratifications above, and then stick with this example, which says even if all you have is an FEV1, if it meets criteria for whatever, moderate or severe, then that's how the patient gets coded.
Okay, thanks.
Okay.
So if people have additional questions about chronic lung disease, feel free to send them in, and we will send those off to Dr. Matchison and get his expert review of them. But we can maybe move on past that.
Good. Not bad. All right. And then so if you want to, yeah, just kind of go down. Let me open this up again. There was a question about liver disease. Hold on. Sorry. Sorry, I'm using my kid's computer and I don't know his password. Give me a second here. There we go. All right. He also had to help me load all these programs today, and he's 10 years old, which is great. Oh, here's one on liver disease. Hepatitis C. So hepatitis C that's been treated, cured with no sequelae. I said in the training to not code liver disease. And then this says historically any history of hep C has been coded as yes. And then they sent a question to STS and Melinda also. So yeah, this is something that I got from Tony. So I mean, whatever, 3 or 4 years ago in one of his sessions that I sat in on. And he said that if there, because this gets at liver dysfunction, synthetic dysfunction, and that's really the risk for the patient. So it is possible to have a diagnosis of hep C, be treated, have zero viral load, and have essentially no effect on liver function whatsoever. So that's why the recommendation at that point in time, and I just kind of carried it forward, and I agree with it too, because the liver is functioning in a completely normal way. I would say no to chronic liver disease or to liver disease. But again, I mean, anybody wants to discuss that, I'm happy to, have that conversation. And let's see if there's another. Okay. That was the only liver disease question there. And then there was an immunosuppression question, which I think is the next one. Oh, yeah.
Sorry.
Sorry.
Sorry, Dr. Matchison. I was muted, but I did want to respond to that hep C question.
Sure.
So I did hear back from Melinda, and she said that hep C, the time frame is from birth to, like the diagnosis of hep C from birth to surgery. So any history of hep C, regardless of treatment, she said to go ahead and code hep C.
Okay. There we go.
Because for me as an abstractor, I don't know if it's been treated, if there's sequelae, if they don't have an ultrasound of the abdomen. I have no knowledge of.
Sure. I can see that.
Okay.
Okay. All right. So we will. Yeah. So going forward, ignore what I said, and we'll do hep C as yes for liver disease. Perfect.
Thank you.
Yeah.
I've got 2 questions in the chat about liver disease.
Okay.
One of them, how fast do damaged liver cells heal?
I would say weeks to months for these cells to reconstitute. I mean, that's roughly.
And then the next one, how should we decide coding on patients who are heavy drinkers for liver disease?
Right. So, we've talked about this, I think, but yeah, even heavy alcohol in and of itself, unless you have some of these other markers of chronic lung disease, should not qualify as liver disease in and of itself. So you need something else, whether it's a history of, esophageal varices or, portal vein thrombosis or, any of these other indicators.
And then another question came in. Is there an STS MELD score level that would allow coding of liver disease equal yes in CCORP?
I think we've tried to stay away from the MELD score because the things that are incorporated into the MELD are affected by so many other things that we're just not using that. So no.
What about cirrhosis?
Cirrhosis is a diagnosis of liver disease?
Must be met.
I think so, but Hans, would you like to unmute and clarify?
You have it.
I kind of heard you.
You have it listed in right in the definition there.
Yep.
So I'm thinking that yes, with cirrhosis.
Yes.
Yeah. Oh, cirrhosis, definitely. Yeah, absolutely. Yeah. It's like the truest form of liver disease.
I think I got all the questions in the chat on liver disease if we wanted to move on.
Okay. I did have one question on immunocompromise. Where is it? Let me get to it. Where'd you go? Oh, here it is. For acute so he said, or the question was, I stated not to code HIV unless this person has AIDS. I don't think HIV is the data element, it's immunocompromise. And so as far as HIV versus AIDS, we would only qualify as immunocompromised if patient has AIDS defining illness like a Kaposi sarcoma or PCP or something like that, or a CD4 count less than 200. So those are kind of the thresholds for immunocompromise in patients who have a history of HIV. Anything else for the immunocompromise?
That's it. I just
Okay.
thought it's a deviation from STS.
Okay.
We'd have to be more specific in the training manual, because right now it just says HIV infection are considered immunocompromised. It doesn't define AIDS or CD4 count or any of the other criteria you mentioned. It just says HIV. So
yeah, I got it. Well, that goes back to like the hepatitis C diagnosis versus liver disease. I mean, in this day and age, remarkably, HIV, I mean, this is a completely curative disease process. So just having a history of HIV infection, in my clinical opinion, again, not as an abstractor, but in my clinical opinion, does not necessarily equate to immunocompromise. If it's been, I mean, that's my take on it.
And here, I mean, examples of conditions causing immunocompromise include, it's a little bit not 100% clear what they mean by there. Yes, it could cause it, but it's a little, their little clarification's not 100% clear.
I got a request for you, Dr. Matchison, to repeat the answer about AIDS a little slower.
Oh, yeah, sure. So HIV obviously has the potential to cause immunocompromise, but the threshold for definition of immunocompromise is a patient with AIDS. And the way you define a patient with AIDS is either a CD4 count less than 200 or ongoing opportunistic infection. And there's a whole list of opportunistic infections, but it's like Kaposi sarcoma or pneumocystis carinii or coccidio, different kind of lung infections. So I would say to qualify for immunocompromise in a patient with a history of HIV, as it stands currently, they would need to meet one of those two other criteria. So either a CD4 count less than 200 or ongoing opportunistic infection.
And I'm going to suggest if people have specific patients that they have questions about on this, they could send that documentation to us and we can look at it.
Definitely.
Since it differs slightly from STS.
Yeah, so 37 is the COVID diagnosis and distinction. Anything? Doesn't seem like it.
So I just want to, and those of you who weren't on our conference call this month, we are going to try to go back and contact all of you to get any patient from the first half of the year who met one of these yes categories, so that we will have that information for the whole year, with the intent of not using those patients in our next public report. Our clinical advisory panel is recommending, as STS is doing, is to not include those patients. We just really can't adequately risk adjust for them. We just don't know. We will then also evaluate those patients, use that cohort for some further review. But just a heads up that we'll be getting in touch with you sometime early next year, probably So if you know of any patients that were yes to any of these COVID 11 through 14 responses, and I'll keep that in the back of your head so that when we contact you, we can add those to our list. Thanks.
Let's see. I did have a question about cerebrovascular versus peripheral vascular disease, which I think comes up here somewhere. And it was just about the definition of subclavian stenosis. And in the video, I said that that is cerebrovascular disease. In going back, I think that should be peripheral vascular disease. So I apologize for any confusion there. But I looked into it a little more detail, and it seems like that's a peripheral vascular disease distinction instead. So that's how I would code that. There was a question as you go through there for the labs, the last creatinine level. Somebody just noted, so the creatinine prior to initiation of anesthesia management, and then it was noted that a lot of pre-op protocols start IV fluids and pre-op upon arrival to the hospital. STS definition currently states, do not use labs drawn after IV fluids are hung in the holding area or the OR. Ideally, yeah, definitely. I mean, you can cause, obviously, hemodilution. So your CBC, your creatinine, all of these can be affected. So ideally, you're not going to utilize that. So it's not just that POCT, that point of care test by the anesthesiologist in the OR, which are almost universally inaccurate. But ideally, it would be a blood count or a blood test taken before IV fluid was initiated.
Any questions coming in, Denise, in the chat? We were at last creatinine. Anybody have any questions for data elements before in the 30s or 40s? And
Not hearing on any questions.
Not, we will start with the 50s, moving on to the 50s.
Excuse me, I just unmuted. I'd had a question about that carotid thing. Could Doctor repeat that? Carotids have usually been a subset of cerebrovascular, I thought. So I wanted to clarify. Any carotid disease is peripheral, not.
No, I'm sorry. Yeah, no. Let me definitely clarify that. Yeah, no. Carotids are definitely cerebrovascular disease. The question was in the video. I said that subclavian disease, which is the blood vessel kind of branching off and going out to the arm. I said that was cerebrovascular, but that should be peripheral vascular.
Thank you. Subclavian. Yeah. Okay. Thank you very much. Thank you.
Yep. Sure.
All right, moving up to Billy INR. Sodium is a new data element, but pretty straightforward. Prior cabbage, prior valve.
I had a question about the prior MI, number 57.
Mm-hmm.
Sometimes it says scar tissue on a stress test or on an echo. Sometimes you'll see it on a CT, but they removed a lot of the criteria in the version change to 4.2 and using those types of tests. So if we see scar tissue on a pre-op test, can we say prior MI yes?
From my standpoint, I would say yeah. I mean, and again, I would open this up to Holly or to anybody else. But I mean, if you identify scar tissue or on a transthoracic echo, you have akinesis or aneurysmal segment of the left ventricle, then to me, that's a prior myocardial infarction. That's the the endpoint of a prior MI. But I don't know if this has been
I think we would
discussed before I
agree,
got here.
especially if STS used to have those in their documentation. Would agree.
Okay. Yeah. Great.
I have a question on number 56, previous PCI interval. Or maybe this is more of a comment for me, but appreciate the clarification given on specific timing interval of time of catheter removal in cath lab to skin incision type in OR. This clarification is not included in the training manual, version 8 or STS. So it would be helpful to have it added if abstraction is expected to be based on this very specific time frame going forward.
Yeah, I saw that. I think that this kind of asks a much bigger question, which is, when does an operation start? You know, what is that time that you're going to utilize? You know, and we've talked about this before, because there's essentially, as far as I can tell, 4 different potentials. You know, it's time into the OR, induction of anesthesia, the actual time out, which personally I think is the most relevant one, because that means everybody's in the room and the surgery is about to begin, or the incision time. So again, this was another kind of holdover from a conversation that was had previously about the time the catheter is removed to the time of skin incision, and that was the duration that we were talking about. So that's why it came up. But I think you know, even offline or in the future, it would be beneficial for us to have kind of one universal definition for the time of surgery. Just because it is kind of a gray area, and there's a lot of debate as to what constitutes the beginning, the start time of a surgery. So that clarifies absolutely nothing as far as the comment, but.
And we'll share your suggestion with STS.
Oh, I'm sure I'll get a reply too.
So on prior MI, I have a question. How about if surgeon states he can see scar from prior MI?
I don't know. I don't know about that. I don't know about what surgeons state in general. Yeah, no, I would want something more objective than a surgeon saying that he sees scar tissue, personally. And I know surgeons. I like surgeons. I know that there is a question for 58 or whatever data element this is. This might be, yeah. So the timing of MI, and so in one of the videos, I don't know if I was adamant about it, but I stated that the onset of the myocardial infarction is the onset of symptoms, as opposed to the first blood draw troponin that comes back positive, because obviously there's a delay, not only a delay in presentation, but a delay in the time that the troponin starts to uptrend, and that can be several hours. So this, I distinctly remember this conversation too with Tony during one of these conferences. And so this was kind of the compromise, is that the onset of the myocardial infarction is timed with the onset of symptoms, which to me makes sense, because, again, from a clinical standpoint, because that's when myocardium is in jeopardy. It's not the first time the troponin comes back positive, it's the chest pain telling you that there's ischemia and there's myocardial damage going on. So that was kind of the rationale there for timing.
I think Heidi G had asked that question and also has one in the chat. Heidi, did we get to answering your question, or do you need some more clarification? Heidi writes in, is it symptom or diagnosis? Clarify the timing. Is it by diagnosis or by symptom? In the video, you mentioned patient at home with CP times 3 hours would take from the time at home. Training manual looks like diagnosis.
Yeah, so I mean, that's exactly. So I mean, that's how I would interpret that, is the onset of symptoms, because that's the onset of myocardial necrosis. But if anybody feels differently, I mean, I'm more than happy to entertain that. But from a clinical standpoint, you know, that's when the implications begin.
And I've got two more questions on that. One of them, so what are the parameters for symptoms? Nausea, back pain, always chest pain?
Yeah, I would say whatever symptom got them to the emergency department. You know, I mean, definitely there's atypical manifestations, nausea, vomiting for somebody who's having an RCA infarct. But I would say whatever the symptom was that brought them to the emergency room, and then subsequently they ruled in for an MI with an elevated troponin or CKMB, it would be that symptom.
And here's a comment. Since the timing definition is different from STS, we would need to manually change that for CCORP after abstracting for STS.
Okay. Okay, again, and then that gets into like the logistics of it. So if that doesn't seem rational, Holly, then, you know, I'm happy to.
Yeah, I mean, if it does, again, want to try to align with them. If there's something that looks like it could go either way, again, you can email us or send us that documentation and we can look at it further.
Perfect.
But let's align with STS.
Okay.
We've got a couple more comments on that. Perhaps the better timing for symptoms could be when the chest pain caused the client to come to the hospital, when it was severe enough to call 911.
Yeah. So again, I think this is just the difference between my kind of clinical thought versus, you know, the logistical aspect of accurate data abstraction. So I think we're just going to go with what STS says then, Holly, and say the troponin or the first diagnosis.
I guess so, yes.
Okay. Sounds good.
And then the question, and what if there is no timing on the home symptoms? Then what is the timing?
Right. So I think at this point, we'll just go with the number, go with the troponin.
Sounds good. One more
Okay.
question. Prior MI, number 57. How would we code an EKG showing inferior infarction age undetermined?
Yeah, definitely not. Definitely does not meet criteria. Yeah. EKG alone is just not sensitive enough for that.
I think we're good to move on to the next data element.
Great. Okay. Okay, so where are we with this?
Failure.
Oh, heart failure? Okay. Surprisingly, I don't think heart failure really generates that many questions. I got nothing.
Okay. We'll move on then. NYHA.
Mhm.
I don't think there were any that came in on NYHA.
No, there's that. Yeah, if we're gonna move through there.
There's a comment. It's just hard to get surgeons to state CHF and NYHA.
Yeah.
Oh, actually, here I have a question. So I was sent that question where the patient was in obvious cardiogenic shock, and I was amazed because nowhere in the chart does it mention heart failure, to the point where the patient is an impella in place, is transferred to a quaternary care facility for cabbage and all this other stuff. So we're saying that if there is not a documentation of heart failure, right, then there's no heart failure? Because it's not the role to interpret the chart and make those diagnoses. And I think that puts people in an uncomfortable and awkward position. So I would say no, as crazy as that is.
Any questions on NYHA? It always sounds good in writing.
Yeah.
All right, let's go to another one of our favorite, cardiogenic shock, which we have now, well, starting with 2020 data, we've been using kind of a revised definition.
Mm-hmm.
And again, as everyone knows, if you code cardiogenic shock, you'll get notification to submit your documentation, which you now can, and you can upload that into CORP. Don't have to fax things in anymore. All right.
And nothing on shock?
Nobody, any questions? Okay, we're happy to move on.
There is a question on shock.
Enough.
Okay.
Yep.
There's the one I sent you earlier with the others, Dr. Matchison.
Yeah, I guess this looked just to me like timing of shock, because it mentions 36 hours prior, and the two shock timing distinctions are at the time of entry into the OR and within 24 hours. So, I mean, we would code as shock here. So the question, sorry, let me say, so if the patient went into cardiogenic shock 36 hours prior to surgery and is still being stabilized with inotropes, do we code this as cardiogenic shock at the time of the procedure? So, yeah, I mean, and this is, this is the nuance of it is, did the patient have cardiogenic shock in the cath lab and then get resuscitated, and then they were initiated on inotropes and have a balloon pump put in, and they just continued with those therapies? The patient, hemodynamically stabilized, they diuresed the patient, whatever happened, and then they just left the inotropes on at a very low level and the balloon pump in place because they didn't want to deal with bleeding from the femoral access site, for example. So that's why these patients, if there's a question with these, I think the best thing is to review it. And Tony did a great job of trying to come up with something that was a little bit more objective as far as like the stratification with dosages of inotropes on board. What's a low dose? What's an actual therapeutic dose? Those kind of things. But I think if, in good faith, the patient is actually being stabilized, is still being supported either with a balloon pump or some sort of ventricular assist device or inotropic support. And if you feel, or again, not you feel, but if it is apparent that if those therapies were taken away, the patient would become unstable, then that constitutes shock.
I've got a question that came in on heart failure. What if the acute STEMI client has heart failure, but symptoms are not manifest until post-op due to urgency of the procedure? There was no history of heart failure in this client.
Yeah, I think that just comes down to documentation. If there's no heart failure documented, then we're not going to code for it preoperatively. No preoperative documentation.
Right.
There was a question that was sent in today on EF number 75.
Mm-hmm.
Please clarify which EF is preferred between a nuclear stress imaging EF or the Intraop T. Dr. M discouraged use of nuclear stress test EF, which is preferred if OR-TEE is the only other EF available.
Oh gosh, yeah. I mean, both of those are pretty bad. Let me see. I think we said the nuclear stress test because there's a lot of things that affect the intraoperative TE. I would say that it's going to be a very rare occasion that a patient has a nuclear stress test and an intraoperative TE, but nothing in between. But let me see here. Just bear with me. What's that data element? What number?
75.
Oh,
EF or 74, 75?
I mean, I guess I would go with the nuke. Begrudgingly. Yeah. Yeah, nuclear stress test. All right.
So we kind of jumped forward a bit there. Were there any questions in the arrhythmia section?
So we're talking about atrial fibrillation, anticoagulation.
I've got a question on EF timing, number 75.
Okay.
STS says to use the closest to time of surgery, which may not be one of the preferred methods if MRI done prior to more recent EF.
Yeah, I mean, yeah, definitely. I would say that even though, yeah, the MRI is probably the most accurate, one of the most accurate ways to assess ejection fraction. You know, the clinical context could have changed dramatically between the time they had an MRI and the time they had their transthoracic echo. So I think by and large, if you have a transthoracic echo within a reasonable period of time, that's probably going to be the best way to report the ejection fraction.
Was that consistent with what STS said?
Let's see, STS says to use the closest to time of surgery.
But again, I guess my point, and I don't know how much I want to kick this horse, but you know, the patient has an echo on Tuesday and then they go for a nuke on Wednesday and then they get a cabbage on Thursday. I would use the echo, the transthoracic echo EF, not the nuke, even though technically it's closest to the surgery.
I would say, again, if you have concerns and if those values are vastly different, you know, send us a question. Hopefully, you know, you said things could change, but they might be close as well.
Yeah.
All right. So we're in the PA systolic, regurg.
And so the valvular heart disease sequence is at this, yeah.
Incidence. Status. Again, if you're coding a patient as salvage, you'll get that email notification to supply us with documentation.
We had a question that came in this morning and it's a rather long one, so I'm going to share my screen so you guys don't have to hear me reading it.
Okay, let me stop my share so that you just do that. Okay, there you go.
Okay. Let's see if we can make this technology work.
Can you make it a little?
You guys see it?
Bigger?
Bigger? Okay.
Okay.
Ooh. Okay,
there you go.
Let's go to status. Can you see it now? That's the number 81. Please clarify.
Mm-hmm.
There you go.
Make it even bigger. Sorry. Making everyone dizzy.
There you go.
Does everyone see it? Please clarify if status is determined prior to patient entering OR or the patient's condition immediately before surgery.
Yeah, certainly this is one that we would obviously review.
Yeah.
Yeah, that one's tough. The timing is insane. I don't know if, yeah, that's just bad for everybody. Let's see.
Sounds emergent to me.
Yeah, I mean, it's definitely emergent. I guess the question is, would it constitute a salvage? I mean, there's no CPR. We don't like to code based on what happens after the anesthesiologist initiates or induces the patient. So I would probably say emergent.
Okay, thank you.
Yep.
Let's see if I go back to my share.
Okay, I released control, so you should be able to do it.
Can you guys see my screen again?
Yep, you're back.
All right. Any other questions on status? And okay, I mean, don't stress too much about this urgent, emergent reason. Just again, don't overthink it. We're not using it for too much, but we continue to, at the request of our clinical panel, continue to keep that question. All right. Perfusion strategy and the next few. CPB utilization, IMA, reason for no IMA, and then the valve section.
Here's the valves, okay.
Don't usually have too much problems with this.
Yeah.
We have a question going back to shock, number 62. We don't get cardiac index prior to induction, and patient may be maintained after acute episode or treatment.
Yeah, I mean, I think that goes back just to the clinical context. I mean, if the patient is being maintained on, 4 inotropes, then that's shock. So you don't necessarily have to have the cardiac output or the cardiac index available to you. I mean, if they have a swan and it's nice, but you and it's tough. I mean, that's why chronic lung disease are constantly the most, debated or discussed, is because it's a gestalt. I mean, it's everything that's going on with the patient at that moment in time. So, they're stable and then they're stable. They're stable on 4 inotropes coming into the OR. And then there's actually a stable, hemodynamically stable patient. So again, sorry, good.
But if they're on 4 inotropes, we still need to see blood pressures, don't we?
Yeah, but I mean, if you have a blood pressure of 110 and you're on 4 inotropes to get there, that patient is in shock. There's no doubt about it. I hope that's not confusing the situation, but a perfusion pressure, a mean arterial pressure greater than 60 is a perfusion pressure. So if it takes you, multiple inotropes or a balloon pump to maintain that, then those patients are in shock.
So we have a question on element number 74. It's one of the EFs. Can we use the Intraop TEE for EF and or valve data elements if the patient has already been induced?
Yeah, I mean, if that's the only information that you have, then that's the ejection fraction that you have to utilize. I did get you guys sent me a question actually that was, a patient was sent to the OR for CABG and there was mild mitral regurgitation on the transthoracic echo. And then the patient underwent induction, had a TEE, and then there was severe mitral regurgitation. So do you code mild or severe mitral regurgitation? For that, I would say that you would utilize the preoperative data, because that's what the operative plan was based upon.
We have a comment on shock. We have never been able to claim shock if they have higher BPs than the stated ones, even on the stated support.
Let me see. I mean, so like when we're trying to clarify for shock here, this is not shock if the systolic is greater than 130, if unassisted and unaugmented, though. So that to me would mean that, you know, the blood pressure is the blood pressure. But if it takes 4 agents to get there, or a balloon pump, and then their blood pressure is 120, again, I mean, clinically, that patient is in shock. So the unaugmented means without I mean, the augmented is the balloon pump, essentially, is what that's in reference to. And unassisted would be off of inotropes.
Here's another comment. Also, if they were resuscitated and the hyperperfusion state is 25 minutes as opposed to 30, and inotropes and balloon pump required to maintain, is it still shock? Should we mark as shock and then send in documents for review?
Yeah, for a case like that, that's exactly what I would do.
And then I've got a type of cabbage question. I think that's data element 2. On a patient getting an AVR, the surgeon found soft, non-calcified white matter in the aorta. When he opened it, so he removed it. He also debrided the leaflet of the mitral valve. Is this still isolated cabbage and valve? Oh, is this cabbage plus valve?
It's not.
Well, it's a cabbage AVR, right? What was the initial planned surgery?
AVR.
Yeah, so it would be cabbage valve. With the debridement and whatever he did to the aorta not being significant. Not being significant enough to change the status of the surgery.
All right, are we back on the valve section now? It sounds like it, maybe.
Yeah.
Any questions on the valves? And then we move on to our complications. Right now, the only one we're publicly reporting on is post-op stroke, but we are considering some of these others. Always and perhaps someday get back to the concept of a composite. So we do look at them.
I've got a question that came in. For the outcome measures, such as mortality and complications, do we extend after patients leave our facility if transferred to another acute care facility, or do we stop as of discharge from our hospital? Similarly, for patients discharged not transferred, do we include complications after discharge if within 30 days after surgery?
So I want to say the only one that, if you do know about it, I feel like is the infection. Yes, deep sternal. If you do know about an infection after the patient has left your facility, please do code that. But you may not know, and they may not come back to your facility. But if you know that, I believe all of the others are, correct me if I'm wrong, anyone, are within your facility.
To discharge, right?
Yeah, to discharge.
Yeah.
Sorry.
Yeah. Yep. I had one, I think, just kind of a clarification for renal failure. Said if a patient's baseline creatinine is 3.8, they're not on dialysis, and then postoperatively it peaks at 4.2, is that renal failure? I think that, yeah, the threshold is an acute rise greater than 0.5. So, I mean, just it would be 3.8 to 4.3. So I think that's pretty straightforward.
Any other questions coming in?
There was a question on neurostroke permanent. I don't remember if I sent this to you, Dr. Matchison, or if it came in this morning.
Okay.
Please clarify if a post-op stroke is determined by symptom resolution, whether within 24 hours or not, which was the older definition, or is it determined by imaging results when stroke is diagnosed? The training video part 2 emphasizes the timing of symptom resolution, whether within 24 hours, like a TIA, or if not, equals stroke, yes. The V8 training manual seems to emphasize or. Confirmed imaging, and the example given is symptoms resolved within 24 hours, but imaging confirmed stroke equals code stroke, yes.
I think maybe what they're getting at is, so when you have that 24-hour threshold, if you have a patient, so the truest definition of a TIA is complete symptom resolution within 24 hours and no neuroimaging evidence of a stroke whatsoever. Maybe what they're asking is if the symptoms resolve, but they get an imaging study and there's some evidence of a stroke, do you code stroke or do you code TIA? I don't know if the person who asked the question is on the call, if that's what they're asking.
I think this was Heidi G's question. Heidi, are you still there? Heidi says yes.
So yes, that answered her question. All right. Any other questions?
Oh, wait a minute. She asked me to unmute her, so let me go ahead and do that. Okay, can I unmute her?
You should be able to, if she's not able to unmute herself. She.
There's a microphone button at the top of the screen that you just click on to unmute yourself.
Any luck, Heidi?
Nope, she's still muted.
Let's see.
It says somebody said microphone is on the bottom if you are using a web browser rather than the app. Oh, Heidi said she called in by phone.
Oh, okay. It looks like she's on there. So let's see.
Heidi, do you want to try emailing me? Look at my emails. Why don't we go on to the other questions while we're waiting?
Sure.
Let's see, there was a type of cabbage question. I've sent this in before, but wanted to hear the reasoning. An AVR plus MVR plus CAB with aortal mitral curtain reconstruction, a commando procedure. I was told to code cabbage plus valve, but this surgery is more extensive. It was due to severe endocarditis.
Yeah, I mean, full disclosure, I'm not completely familiar with that particular surgery. I would have to actually look into it and see how involved it was, and then kind of use that information to determine whether or not it should be excluded.
Yeah,
I mean, if you're doing like
there's not a procedure that would necessarily make it other, but if they want us to review it, they can send the documentation in.
commando procedure. Nice.
And if that's okay. Yeah, please send it in.
Here's one. For acute care transfers, STS wants all post-op events, complications at the second facility. This is different from CCORP, correct? CCORP timing stops when they leave our facility other than infection. Is this correct?
Oh, so now they're asking for all of the complications to be through the next.
Holly, do you really want that?
No, because yeah, I would just put what you know at your facility. If we know we're going to start using these other complications, we will discuss it further. But yeah, it's really hard to know that you're getting the best information when you guys are relying on what happens at another facility. We do, yeah, for stroke, definitely stay with what happens up until discharge at your facility.
I would definitely say, I would echo that and say, especially when they're going to an acute care facility. I mean, it's just very difficult.
And now I have a question on number 102, other AFib. In the past, CCORP has stated that the AFib must last at least an hour to be captured as yes for CCORP. Is this still the case, or is CCORP aligning with STS, which states if the patient is treated for the AFib, regardless of how long it lasts, it is captured as long as the patient was not in AFib upon entry to the OR. Example, patient goes into AFib, amniobolus given, and patient converts to SR. AFib only lasted 30 minutes.
I think if you look at it, we're going to align with that definition that is there, where if it lasts less than 1 hour but requires medical or procedural intervention.
Yeah, I agree completely. I mean, it's treatment rendered. I mean, patients going to AFib, they're post-operatively, they're going to get treatment with sooner than 1 hour. So, yeah.
And then a question, when we discharge to an LTAC, we still code this as ECF. I would think no, because LTACs are not acute care hospitals, are they?
No, long term, no.
And then let's see, a comment. STS has changed how long they want us to try to count complications, and when we say discharge, to extend to the second facility. It's really hard to get this information. Maybe we need to add two elements for CCORP that are unique: complications prior to discharge from index procedure hospitalization date.
Thanks for the suggestion. We can't add data elements at this point, but I think one of the reasons we want to stay with what happens at your facility is we know how hard it is to always follow these patients, and we feel we have much better data that is consistently coded to use for outcomes if we have you all code based on what's at your facility. You know, again, if you're coding for STS, please do what they want you to do. You can, I think, modify that data for us if you have to. The one we're most concerned about is stroke, because it is what we publicly report. And if they had a, you know, if they have a stroke after leaving your facility, and we're not counting that against other hospitals that didn't code it. So you would want to maybe definitely change that to only if it was within your facility. Discharge before discharge from your facility.
And I also think that you don't want the initial treating facility to be penalized for gaps in care that happen at a different facility that aren't necessarily directly related to the index surgery.
I think
So,
that
right.
the surgeons would feel that way, and that the surgical team and the hospital, I think it's been our argument all along, when they first started, when they added the discharge date being the discharge from the final long-term care facility, you know, that you don't have control over that treatment of that patient after they leave your facility. So right. We don't necessarily support STS's decision to do this.
So Heidi was able to write in on stroke, number 98. Is my understanding correct? We should code stroke yes when there is imaging evidence of stroke, even if symptoms resolve in 24 hours. This is supported by the example in the version 8 training manual asking for clarification because the training video focused on if symptoms resolved in 24 hours, then code no. It does not address the imaging component.
Yeah, I think if you have neuroimaging after 24 hours with evidence of stroke, then you would code stroke. Yeah, not TIA.
And then I had a request to please repeat the Afib complication equals yes definition.
So atrial fibrillation postoperatively would be coded yes if treatment is rendered, either cardioversion or chemical cardioversion like amiodarone, or if it lasts greater than an hour, either or. So the only way Afib is encoded as yes is if they're in atrial fibrillation as they roll into the operating room.
And then I got a question by email about the COVID. I think this is for Holly more than anybody, but for COVID patients, that they will be exempt from public reports. Is this only for patients who test positive while in the hospital or any of the other responses?
It's going to be STS is exempting from your STAR reporting any of the yes categories. Even if it's COVID after the cabbage, we're just still not understanding the extent to how much damage this COVID is doing. And if you've listened into any of the STS webinars, we had a scenario at the last CAP meeting where they actually had a patient die that had waited 30 days after having COVID, and the patient died, and they said on autopsy the lungs were just a mess. So we're just not really understanding if they had COVID after and then they died, that would be an unfair rating. So any of those yes values will be pulled out from the public reports. So, if you're within those time frame of that, those yes questions, the yes responses on the STS question. Thanks for asking.
Thank you. In regard to the aortal mitral curtain reconstruction question, we do similar procedures with the addition of an L-vote. We call it a double patch, double valve. It's an unusual, very high risk procedure, and it is an other. And here's a question back on stroke. Stroke is a stroke if positive imaging, even if symptoms resolve. For stroke, if symptoms less than 24 hours, but there is positive imaging, I thought, yes, stroke.
So this is what I would say about stroke. If there's neurologic deficit that resolves before 24 hours and there's no neuroimaging, that's a TIA. If there's neurologic deficit that resolves before 24 hours and there's neurologic imaging and there's no evidence of scar essentially in the brain, that's a TIA. If there's neurologic deficit that resolves before 24 hours, there's neurologic imaging that there's scar in the brain from a stroke, then that's a stroke, even if the symptoms resolve. I liken it to a patient who has a history of stroke, but then has no focal neurologic deficit after 24. A patient who has a stroke and they have deficit beyond 24 hours, but then, 6 months later, they have no focal neurologic deficit. That patient forever has a stroke. So I would say that if there's neuroimaging and it correlates with the neurologic deficit, because we've had that question too. I mean, a patient has stroke-like symptoms or a neurologic deficit, it resolves within 24 hours, then they do neuroimaging, and a patient has evidence of old stroke, do they have a stroke? No, they had a TIA. But as long as the neuroimaging correlates with the focal neurologic deficit and there's evidence of scar or stroke on the neuroimaging, I'd say that was a stroke.
That's the end of the questions I see in the chat or that were earlier emailed. Are there any other questions out there?
Okay.
Oh, let's see, here's one. Oh, they're starting to come in now. Incidents. STS has added procedures that involve disruption of pericardium to be considered as prior CV procedure that impacts incidence. ICD lead removal we are now supposed to consider this a yes for prior CV surgery. This really muddles the waters on this element and a highly weighted risk stratification, in my opinion. Has CCORP adopted these additions of type of CV procedure for incidents?
If it's is it in the training manual, in the STS training manual? Am I still muted? No, I'm not muted.
Nope.
I've pulled it up. I'm trying. I have our training manual up. So is that a clarification on their new, or is it from their definition, or is it a new clarification? Because we will continue to align with them.
There have been a bunch of STS updates on incidents since June.
Okay.
So we'll have to review them and add them. We just didn't add them for now because it was going to throw off the slide numbers, but right. There are a whole bunch.
Okay. We will get those looked at and forward them to Dr. Matchison. And, I think we're up on, for our first of the year, we will be having our data managers conference call. So hopefully we can address that at that call. But likely we will adopt all their clarifications. Even though it's muddled.
Oh, I'm sorry. One last thought on coding chronic lung disease on FEV alone. We must all use our clinical judgment and not overcode when patients are decompensated heart failure or poor results, DT sedation or balloon pump, etc., as Dr. M mentioned in the training video.
Yeah, again, I mean, I think, was that Dottie? I feel like that's always Dottie raising that question. Yeah, I mean, that's why it's such a difficult data element, because there's a lot of stuff that can acutely affect the value of the PFT. And that's why I think there's a danger in just going with the PFT value, especially when a patient doesn't have a pre-existing diagnosis of chronic lung disease of some sort. But I mean, we just have to make a decision as to which direction we're going to go in and then stick with it.